Today we're jumping into something, well, pretty common but definitely alarming when it happens. Bell's palsy. You might also hear it called idiopathic facial paralysis.
Right.
Our mission today is really to get under the hood of why this sudden one-sided facial weakness occurs. And maybe even more importantly, how doctors figure out quickly that it's not something much scarier, like a stroke.
It really is like a sudden short circuit for one side of the face. Bell's palsy, by definition, is that rapid onset of paralysis affecting the facial muscles. And it happens because cranial nerve 7, that's the facial nerve, just sort of stops working.
Okay.
And when we look at the nerve itself, the research is quite clear. This is what we call a lower motor neuron lesion.
And that term, lower motor neuron lesion, that's actually really key, isn't it, for understanding what the person feels. I
Absolutely.
mean, the damage is to the whole nerve pathway after it leaves the brainstem, not just like a partial glitch from somewhere higher up.
Exactly. It's a complete shutdown of that nerve's function on one side. And it is surprisingly common. I mean, Bell's palsy accounts for maybe 60, even 75% of all cases where someone has paralysis on just one side of their face.
Wow, up to three-quarters.
It-
That's huge.
It really is. The median age it hits is around 40, but honestly, it can affect almost anyone. And while that word idiopathic technically means we don't know the exact cause for sure.
Right. Idiopathic always sounds a bit like we're stumped.
Huh, yeah, a little. But almost all the current thinking, the research, points pretty strongly in one direction: inflammation. Specifically, inflammation often triggered by viruses that are already hanging out in the body.
Okay, let's unpack that viral connection then,
Okay.
because it sounds like the foundation for understanding this. We're talking about viruses we already carry, dormant ones.
Precisely. The usual suspects are herpes simplex virus 1, that's the one causing common cold sores, and herpes zoster virus, which you know from shingles and chickenpox.
Right.
The main theory is that these viruses, which kind of live quietly in our nerve ganglia, suddenly reactivate.
Wake up, basically.
Yeah, they wake up. And that reactivation causes a big inflammatory response, swelling, irritation right there in the nerve tissue. Now, the facial nerve runs through a really narrow bony tunnel in the skull.
Okay.
So when it swells up from this inflammation, it gets compressed in that tight space. That cuts off blood flow ischemia and can strip away the nerve's insulation, the myelin. The nerve essentially gets choked.
And is this where some of the newer research comes in? Updating the list of potential viral triggers?
Yes, exactly. Beyond those classic herpes viruses, there's growing evidence linking others like Epstein-Barr virus, cytomegalovirus, and really importantly, in recent years, there's been a clear link established between infection with SARS-CoV-2,
The COVID-19 virus.
the COVID-19 virus, yeah, an increased risk of developing Bell's palsy following infection.
That's significant. It really highlights how a systemic viral thing can have these specific neurological impacts.
It absolutely does. And interestingly, along those same lines, some research has noted a possible association, maybe a slight increase in risk, shortly after certain vaccinations.
Okay.
Which again points back to that core idea. It's often an inflammatory or immune response kicking things off, whether that response is fighting an active virus or reacting to a vaccine. It triggers the swelling, then the compression.
So mechanism is inflammation leading to compression.
Yeah.
Does that mean we should look beyond just viruses? What about bacteria?
We definitely need to. Lyme disease is a well-known bacterial cause. It's caused by Borrelia burgdorferi. Clinicians sometimes use that mnemonic, BAKE.
Bake. Let's see. B for Bell's palsy.
Right. A for arthritis, K for cardiac block heart issues, and E for erythema migrans, that classic bullseye rash.
That's a really helpful mnemonic. And it underlines the point, right?
Yeah.
If it is Lyme, the treatment approach changes completely. You're thinking antibiotics,
Yeah.
not necessarily antivirals or just steroids.
Exactly. The cause dictates the immediate therapy. There are also looser associations with other bacteria like mycoplasma, maybe syphilis, and just generally people with certain autoimmune conditions seem to be at a slightly higher risk, which again ties back to that idea of underlying inflammation or immune system readiness.
Okay, let's shift to risk factors then. Who's more likely to get this, and what kind of things might actually trigger the onset? We mentioned the average age is around 40.
Yeah, older age is one factor, but there are some specific health conditions that really stand out. People with diabetes, for instance, they have a notably higher risk.
Interesting.
Same for people dealing with obesity or hypertension. And pregnancy is another big one, especially during the third trimester.
Wait, so pregnancy or diabetes, how do those conditions make the specific nerve in the head more likely to get compressed? Is it just general inflammation again or something else?
That's a great question. With diabetes, it's likely linked to overall higher susceptibility to inflammation and maybe slower recovery from any nerve irritation. But with pregnancy, particularly later on, there's significant fluid retention and, well, generalized swelling happening in the body.
Oh, okay.
So the thinking is that extra fluid and maybe the altered immune state during pregnancy just make that bony canal holding the facial nerve even tighter. It makes the nerve more vulnerable, so any little trigger, any bit of inflammation is more likely to cause that critical compression.
That makes a lot of sense. So what about the immediate triggers? The thing that happens right before your face droops?
Well, the one patients often mention, the sort of classic story, is exposure to cold wind, especially hitting one side of the face.
Huh. Like driving with the window down?
Something like that, yeah.
Hmm.
And then, given that strong viral link we talked about, having what's called a viral prodrome is really common. That just means symptoms before the paralysis starts.
Like what?
Like maybe an upper respiratory tract infection, a cold, or perhaps a cold sore just flared up from that HSV1 virus.
And that connection. Colds, cold exposure.
Yeah.
That fits with the timing too, doesn't it? I think I read Bell's palsy is more common in winter.
It is, yeah. Demonstrably more common in colder months, which just reinforces that whole viral theory. It all kind of links together.
Okay, let's really drill down into the nerve itself now. Cranial nerve 7. Because the symptoms are just so varied, almost bizarre sometimes. What does this nerve actually do? And how does injuring it, say at that geniculate ganglion spot, cause all these different problems?
Right. CNFS is a real multitasker. It's got its fingers in a lot of pies, so to speak. Primarily, it controls all the muscles you use for facial expressions: smiling, frowning, raising eyebrows, closing your eyes tightly.
The basics of showing emotion on your face.
Exactly. But it also carries taste sensation from the front two-thirds of your tongue. It helps manage tear production in your eyes and saliva production in your mouth. And this one surprises people. It plays a role in how you perceive sound through a little branch called the chorda tympani.
So when that nerve gets inflamed and squashed, maybe from a virus waking up in the geniculate ganglion,
Yeah.
that explains why it's not just about losing your smile.
Yeah.
Someone might suddenly find everyday noises painfully loud.
Precisely. That symptom, the extreme sensitivity to sound, is called hyperacusis. And it's a pretty specific sign that that chorda tympani branch, the one involved in sound damping and taste, is affected.
Okay, now for the really crucial part, the part that probably causes the most anxiety, that sudden onset and figuring out what's really going on. You mentioned it comes on fast, like within 2 days, maybe even overnight. How do doctors distinguish this from a stroke?
This is the absolute critical point in the ER or the clinic. It's a high-stakes diagnostic moment. Because Bell's palsy is that lower motor neuron lesion we talked about, the paralysis affects the entire nerve pathway below the brainstem.
Okay.
Therefore, the key clinical sign, the thing that absolutely has to be there for it to be Bell's palsy, is that the weakness affects both the upper part of the face, meaning the forehead, and the lower part of the face.
Yeah. So if someone comes in, their mouth is drooping, but they can still wrinkle their forehead perfectly fine.
That is a major red flag. That suggests the problem isn't in the facial nerve itself, out in the periphery. It suggests the problem is central, likely in the brain.
Like a stroke.
Like a stroke, or potentially some other lesion in the central nervous system. If the forehead is spared, you have to think central until proven otherwise. That's why the physical exam is so focused. Can you raise your eyebrows, close your eyes really tight against resistance, show me your teeth, puff out your cheeks?
Got it. So checking those upper facial muscles is paramount. What about other symptoms? Are there sensory things that help clinch the diagnosis or raise concerns?
Yeah, definitely. That impaired eyelid closure is a huge practical concern. The eye can't blink properly, it doesn't close fully during sleep.
Risking damage to the cornea.
Big time risk of corneal abrasion or drying. So immediate eye care lubricants, maybe patching, is essential. On the sensory side, patients might report that loss of taste on the front of their tongue, the hyperacusis, that sound sensitivity we mentioned, and changes in tearing, either too much or too little, or dry mouth.
I think I saw somewhere that pain can actually come first,
Yeah.
before the face droops.
That's right, yes. Some people experience otalgia, which is just ear pain, or pain right behind the ear over the mastoid bone, and that can happen hours, maybe even a day or so, before the weakness becomes obvious. It can be like a little warning sign.
Okay, so given all these potential symptoms and the absolute need to rule out a stroke quickly, the diagnostic process sounds pretty intense, especially since you said there's no single test for Bell's palsy itself.
Right. And this is maybe the most important takeaway for you, the listener. Bell's palsy is a clinical diagnosis. And crucially, it's a diagnosis of exclusion.
Meaning you confirm it by ruling out everything else it could be.
Exactly. There's no blood test, no scan that definitively says, yep, Bell's palsy. The entire diagnostic effort is focused on making sure it's not something else.
So primarily ruling out stroke, checking for slower onset, maybe double vision, other neurological signs that point towards the brain.
Precisely. And then also considering and ruling out those other potential causes we discussed, Lyme disease, maybe screening for HIV or syphilis if the history suggests it, checking blood sugar for undiagnosed diabetes.
Are there any supporting tests they might use?
Yeah, they might do things like a Schirmer's test to measure tear production, or a stapedial reflex test, which relates to that sound sensitivity. These can help confirm the nerve pathway involved. But ultimately, the diagnosis rests on that classic presentation. Rapid onset, unilateral weakness involving the entire face, including the forehead, and no other neurological signs pointing to a central problem. Oh, and they might use a grading scale, like the House-Brackman scale, just to assess the severity of the paralysis.
That initial 48 hours sounds like a real pressure cooker for the clinicians. But the good news, thankfully, is that for most people, the outlook is pretty positive, right?
It really is.
Yeah.
That's the upside here. Bell's palsy is often self-limiting. Somewhere between 80 and 90% of people will have a spontaneous recovery.
Wow, that high.
Yeah, a very good prognosis overall. Improvement usually starts within about 3 weeks, and full recovery often happens within, say, 6 weeks to 3 months.
But you mentioned earlier those risk factors, diabetes, obesity, hypertension. Those folks might have a tougher time getting back to 100%.
That's correct. Having those underlying conditions does seem to correlate with a lower chance of complete, perfect resolution. And we should also mention recurrence. It doesn't happen to everyone, but somewhere around 8 to 12% of people might experience it again later in life. Seems slightly more common if there's a family history.
Okay. So if recovery isn't happening quickly on its own, or if it's a severe case from the start, what's the treatment plan?
The cornerstone of treatment is really about tackling that inflammation and nerve swelling as quickly as possible. So corticosteroids, prednisone is the common one, are the main therapy. Starting them early seems to improve outcomes.
And what about antivirals, like a cyclover, since viruses are the likely trigger?
That's a bit more debated. For severe cases, antivirals are often added alongside the steroids. The evidence for antivirals alone isn't as strong as for steroids, but the combination is frequently used, especially if they suspect herpes zoster is involved, like in Ramsay-Hunt syndrome, which is related.
And eye care. We keep coming back to that.
Can't stress it enough. Because that eyelid isn't closing properly, protecting the cornea is crucial. So artificial tears, lubricating ointments, maybe taping the eye shut at night, it's non-negotiable to prevent long-term eye problems.
Is surgery ever an option?
It's generally reserved for very severe persistent cases. If nerve function tests, specifically one called electroneurography or ENG, done between day 3 and day 14, show really significant nerve degeneration, like 90% or more damage.
Okay.
That suggests the chance of spontaneous recovery is quite low. In those rare situations, surgical decompression of the nerve or maybe procedures to help the eyelid close might be considered, but it's definitely not a first-line treatment.
So this deep dive really highlights the interesting nature of Bell's palsy. It's incredibly common, technically idiopathic, but almost certainly linked to these latent viruses waking up and causing inflammation. Plus, new factors like SARS-CoV-2 complicating the picture.
It's a fascinating window into neuroinflammation, absolutely. How the immune system interacting with a virus can have such specific, localized effects.
Which brings us to a final thought for you, our listener, to maybe chew on. We've stressed how vital it is for clinicians to distinguish Bell's palsy from a stroke, often under intense time pressure in those first 48 hours. We know new viral triggers like COVID-19 might be muddying the waters diagnostically. So how critical is that one simple clinical observation, the fact that Bell's palsy must involve forehead weakness as the fundamental safeguard in making that urgent, potentially life or death distinction?
It really underscores how sometimes in the complexity of medicine, the most basic physical exam finding holds the most diagnostic weight, especially in an emergency.
Definitely food for thought. Thank you for joining us for this deep dive today. We hope you found it insightful, and we encourage you to keep exploring.
Hi there, forest friend. Thanks for clicking on our video. We're so happy you're here. Before we jump in, don't forget to like, subscribe, and share this video with your friends.